let's just rush through this. So, in to say that I lot to say, and if we don't finish it all, that's okay. But a lot of it is, I know that you had a patient you've already treated with CAR T for ALL, and one of the questions is, what do you do with them long term? And I was trying to get to that answer.
I can't hear you.
Oh, I'm not mute. I'm talking. Can everyone?
I can hear you. Dr. Surapal, maybe it's your connection. Can you hear him, Jenny? Wanapa?
Hello,
Yeah,
hello.
I can hear you.
You can hear.
Boy.
Jenny, can you hear him?
Yeah, I can hear you guys.
So
Hi there.
We can hear you, Richard. I think it's just Dr. Surapal.
Okay.
Dr. Surapal, can you hear us?
I can hear you, Richard.
Keep talking, Richard.
Okay, well, this is a disclosure slide. We could skip that because that's sort of irrelevant here. Next slide. Next slide was a big slide, an important slide. So can you see that or hear that, sir?
Yes, we can hear you.
Hello.
Okay.
I can't hear you at all.
Oh, shoot.
Dr. Surapal, can you log back in again? Because we can hear him just fine. Wanapa, can you hear us?
Yes.
Okay.
Okay.
So it must be on. Okay, Wanapa can hear as well.
I'll give him a call and ask him to sign out.
Yeah, we can hear you just fine, Richard. So it's not on our side, it's on his side.
Okay. Restart. I'm just sending him a message. So, okay, well, what I was...
เอาเข้าใหม่ใช่ไหม
ค่ะอาจารย์
โอเคได้
You can hear him just
เท่า
fine.
ไหร่นะ
Is it really
More I teach.
Is that more really 12 pounds of burden from leukemia?
Yeah.
Yikes.
So that's why this was a way to as an introduction is for people to understand better about leukemia. And I don't know who, well, maybe we could just, I'll just start and we'll catch up, is when you actually do the math, if someone comes in with a white count of 100,000, and which we see frequently, and you do a bone marrow, it looks like what we see in the upper right, like it's filled. And then when you do a marrow, you see the path report comes back and say, it's 100% blast, and it's solid, and it's not aspirable. You put a needle in, you can't really suck anything out because there's no fat. It doesn't collapse. The marrow actually takes on the context. I always say the texture of steak. It is just a solid mass. But then if you actually figure out what the volume, what the intravascular volume is, what the vascular volume is, how many cells are there, and also what the weight of the bone marrow. There's old calculations that the adult bone marrow weighs 4.8% of your body weight. So this was a hypothetical 90 kilogram person, which actually, if you figure out, you will present, when someone comes in, they have 5 kilograms of leukemia. And so that's when everyone that says, I'm going to worry about tumor lysis, they worry about all those cells breaking. But what I did was, what does 5 kilograms look like? And that is a picture of a 12-pound roast, because that is how much leukemia is in your body when you walk in and with a high disease burden. And again, it's a way to visualize it and send the message. So when we see something that is like a golf ball size, lung cancer, we say, wow, that thing is huge. In retrospect, that golf ball size lung cancer is tiny compared to what we see when a patient comes in with, blast phase of acute leukemia. Next. Can you hear now, Dr. Surapal?
Yes, I hear you very well.
All right, great. So this was an attempt to say, over the years, this is SEER data, like is the epidemiology data over basically 3 decades, showing that, or 2 decades, showing that we've gotten better for survival. that, but young kids do well. But if you look at starting age 15 to 19, we have a lot of trouble with keeping people alive. And by the time they're 40, long-term survival is really impaired. So adults, ALL is childhood leukemia. 85, 90% is childhood. But when adults have this, it's a very, horrible disease, and it does need aggressive therapy. Next slide. So when we talk about ALL, these are the questions that come up. I'm not going to concentrate on the upfront stuff like, can we get higher remission rates? Can we find ways to decrease relapse? Can we identify those subsets who don't need an allogeneic transplant? Because right now, especially in adults, almost everybody we consider as an allogeneic transplant. And as far as what happens when you relapse, I'll show you a slide that can you actually recapture disease control, because most patients don't get there. So all of your benefit is in your upfront treatment. And then, of course, how we treat ALL is always how do we be as aggressive as possible. And what you want to do is the more aggressive you are, the more non-relapse mortality. So you want to reduce toxicity. And again, these are the transplant approaches. Next slide. So when we look at transplant, we recognize that even if we do transplant, we can get patients to remission, but there's still a high risk for relapse. And we know that there is a graft versus leukemia benefit, but it's not as strong as for lymphoid blasts as it is for myeloid blasts. The graft versus leukemia benefit for AML is much greater than ALL. And so therefore, what do? We say, well, we need total body irradiation. We need a more intensive regimen, and thus we have more toxicities early with mucositis, pulmonary toxicity, IPS, and there's late effects, chronic GVHD, organ dysfunction, long-term, and second malignancy. Next slide. And so this is just a reminder, just a couple slides on adults. So if you look at CR1, this is the data from pretty much the last decade from the IBMTR. This is not old data. These are relatively new data. And for patients transplanted CR1, we only have 6 out of 10 people alive at 5 years. If they're in CR2, it's down to 40%. But interestingly, we know ALL tends to be bad, but even for refractory leukemia, patients who never get to remission, you still get about 20 to 30% of patients can be cured if you take them to an allogeneic transplant. Next slide. And this shows that we've gotten better over time. If you look at outcomes, all outcomes of all adults, by 5-year decrements, you can see that we're increasing our ability to keep people alive. And a lot of it is a combination of 2 things, I think, or 3 things. 1, better supportive care. Second is better diagnostics. So we're getting deeper and deeper in understanding measurable residual disease far better. And we also have new agents that can deepen the response. And I'll just show some very brief look at that. Next slide. So this is a reminder of the ECOG MRC study. Jacob Rowe published this originally. Anthony Goldstone gave the follow-up final data. And the data doesn't look good. This is for basically adult patients. It was a combination of one of the United States intergroups and the British Medical Research Council approach. It's statistically significant, though, that you do better if you had an allogeneic transplant than if you didn't. So overall survival, as you can see, 0.02, you do better. It's better if you have a donor for overall survival. It does turn out that standard risk disease, which is graph C, you have a statistically significant benefit of survival if you go to allotransplant. If you have high-risk disease, though, like white counts over 100,000 on presentation, the 411 translocation, and high risk was defined as over age 35, there really wasn't a really good benefit because there was such a marked increase in non-relapse mortality. And thus, a lot of the emphasis, since this study was done in 2001, a lot of the emphasis was, can we do better in our older patients? And older in ALL is over age 35. Next slide. So this is the myth of second remission, that same study from the combined MRC ECOG data. What happens if you had the patients who relapsed on the study? So they had a transplant and relapsed, or they never were able to go to transplant and relapse. How successful are we at keeping them alive? And you can see it's pretty poor. So we pretend to ourselves that we can do things, but when you have relapsed ALL beyond the first remission, you know, outcomes historically, and this is a important to know, this is also a clinical trial, and a clinical trial tends to select better patients for enrollment than just standard of care, you know, real world data. Next slide. So a meta-analysis, this is just showing when you look at, you know, outcome of over 3,000 patients with Philadelphia negative ALL, what predicted outcomes was for better outcomes is if you're young, if you're male, if you have standard risk disease, and those combined, those were the ones, the factors. If you see that, they definitely do better with allo transplant. Everything else is sort of, there's a trend to better allogeneic outcomes, but at the end of the day, we still need something better. Next slide. What can we do? And this is, I think, the product of some of the innovations of the last 10 to 15 years, is we identified, for instance, these are 3 new approaches that we can improve potentially the outcomes of ALL and transplant. One, if you have CD20 positive B-cell ALL, you can use directed immunotherapy. We now know that pediatric patients, we can intensify pediatric type regimens and move it to the young adults, and we can select and identify patients at higher risk for relapse. Next slide. And so this is a study from Germany, which has actually looked at the question of, if you had a CD20, the subset of patients with CD20 positive ALL, all they did is, it's a standard ALL induction, but they added Rituxan. And you can see that there's a 15 to 20% statistically significant improvement in overall survival in patients where Rituxan was introduced. And so now that's a really critical measure when we have adults or ALL. We look for CD20 expression, and we have rituximab is added to those patients. Next slide. Now, what about pediatric versus adults? So this was a study that came out of Wendy Stock at University of Chicago. You know, University of Chicago in the United States has been a long-standing adult ALL center of excellence. Richard Larson was the head of the ECOG group. Wendy Stock is there. And the figure on the left was a paper from 2008, which said, you know, when we look at the likelihood of adults and or even young adults versus, you know, pediatrics, what's the chance of being alive? And this was basically the same age group patients treated on either a pediatric, the Children's Cancer Group study, or the same age group treated on an adult study with CALGB. And there was a dramatic difference, a statistically significant difference in survival at 7 years. So the exact same age group, this wasn't saying old people and young people, it was the matched age group and a pediatric regimens, which tend to be more intensive and for longer periods of maintenance. They treat, it's a minimum of 18 months of treatment. They had better 7-year survival. And so Wendy Stock and ECOG and CALGB basically started a study for adult patients age 18 to 39, and they treated them using a pediatric regimen. So this is the AYA, the adolescent young adult group, and you can see now, instead of having a 40% survival at 5 years, it's now estimated at 60%. So pediatric inspired therapy, more intensive therapy for induction can be given, and a lot of these patients still go to transplant, but it does. Next slide. For this is the same. Next slide. I'll skip that one. The other one is, can you overcome this? And now we're looking at detection. And so they asked the question is, if we have better understanding of disease, can we do better for patients? And this is where, instead of when you look under the microscope, for blasts, you can say, by eye, you can see 1 or 2%. But this is now using a flow cytometry where they can say, they can identify ALL, persistent ALL in the bone marrow at less than 1 in 1,000 versus greater than or equal to 1 in 1,000. And you can see that at the sensitivity, transplant was effective. And even if you still had higher than that, transplant was effective. If you did not have a transplant, though, and you have MRD measure, persistent disease, because these are young patients, age 15, well, maybe they don't need a transplant, their survival was impaired. So now our diagnostics are coming to bear to help allow us to do a better outcomes. Next slide. So we've still even made more improvements of ALL. And these are the advent of bispecific antibody, blinatumomab, or an immune conjugate with inotuzumab. Next slide. I just took, as a reminder, these are the data. So this is blinatumomab. Now, blinatumomab is basically immunotherapy. It's going to couple your host immune cells to your residual ALL. These are relapsed refractory ALL. And what it did is showed a statistically significant improvement in overall survival when you use, compared to the best possible salvage chemotherapy for relapsed leukemia. I'll also point out the right side of that Kaplan-Meier curve, though, is you still die. The blinatumomab is a bridge to something, but by itself is not creating new cures. But transplant can actually enhance this, and that's what the show on the right shows, that you are still be able to, if you censor at the time of transplant, your survival rate actually increases. Next slide. Inotuzumab was also, now this is an immune conjugate. It sees a new molecule. It's targeting CD22. It's coupled to calicheamycin, just like the old Mylotarg is. And the calicheamycin study here, again, this is relapsed refractory ALL, not using this as primary treatment to cure somebody, but can you get better disease control? And it is, again, a statistically significant improvement in progression-free survival. Again, we can't rely on this as a curative therapy, but we can use it to help us get to somewhere we want to go. Next slide. So what are our current unmet needs? This is a slide for pediatric, and we could actually, use the same type approach and say, what are our unmet need for adults? We need better induction regimens that are going to be more successful, because you can now identify endpoints. So at the end of month 3, if you are failed to get a deep, complete remission, or you're still MRD positive, that predicts for only about a third of patients being alive at 5 years. If we have patients who have high-risk disease, like the 411 translocation, or the inversion 3, which can be seen in ALL, or even what used to be Philadelphia positive ALL, not anymore, we only had a 20% survival at 5 years. So once they relapse, standard risk relapse, so standard risk disease, young patient, but has high risk cytogenetics, poor outcomes. Again, relapse has poor outcomes. And if you had an allogeneic transplant and you relapse, the best 1 or 2 year survival is 10 to 20%. Now that is the situation we are before we move into CAR T therapy. So we have definitely improved the outcome of patients with ALL. We know it's a challenge to manage someone with ALL, but we can cure people, but there's a lot of people that aren't cured. And so the question is, can we do better? Next slide. Now, this is a case, I just want to mention that, I just threw this in there. This is a patient of ours. And this is a woman, 62-year-old, who had Philadelphia positive ALL, received induction therapy with a tyrosine kinase inhibitor and chemotherapy, got to complete remission, and we took her to transplant. Reduced intensity appropriately. However, soon afterward, she had a relapse. So we treated her with a second generation TKI, got the disease somewhat under control, and then gave her blinatumomab. It turned out she progressed on blinatumomab and now had a new mutation of the ABL gene. And so we gave her dasatinib and radiated her extramedullary disease, and she had a partial remission only. And then she started to develop a new disease. And so we gave her inotuzumab and then induction therapy, and we got her into complete remission. And then while we were there, she got pretty debilitated, and she progressed. And so we gave her ponatinib, and then she had fulminant relapse. We gave her more chemo and yet a fourth generation TKI who got her into third complete remission. She was hospitalized for 2 months. She was on a ventilator, dialysis, ICU support, and she actually survived and got better. We actually took her to CAR T then. We took her when she was improving. Her ECOG status was probably a 3 for most of it. We manufactured CAR T cells, and while we were waiting, her disease progressed again. She now had both bone marrow disease, blood, and extramedullary disease. And we just said, let's give her CAR T. Gave her CAR T. She is now, by 1 month, she was in complete remission. And what I now can tell you is she's 6 months out in continuous remission. Now, I don't know if we've cured her, but I will tell you that there's no way that this person would have survived previous. And the big question is, what do we do now with her? Right now, because she's been debilitated, she is doing relatively okay, but we are closely monitoring measurable residual disease with the hope that while we help her convalesce, she could be a candidate for a second transplant from another donor if we start to see that the CAR T is failing. Again, and up on the upper bit is just showing her BCR-ABL going up, and the different times it went up a long way. It is a very sensitive tool, and you can see all the way on the right-hand side that it's down to 0. So that's with the sensitivity in 1 in 100,000. So we trust that she's in a good remission, and in a way, is this a good use of resources? That's a different ethical question, but this is a patient we cared for and that is now alive when normally would have been dead. Next slide. So this is a remainder. I said, now where does CAR begin? It started in the laboratory, and we don't have time to spend much on this, but I'll just point out this was a study from Sloan Kettering where they created the animal, it's an animal data, they created a CAR that would see CD19. And this is their CAR, and they used it in a mouse model, a xenograft model. So they made human CARs, they put the human tumor in the mice, and what you can see is, like in the upper part, the upper graph, the red is like how fast the disease grew back without the CAR, with the placebo, and those with the CAR, and that's what you can see in the pictures in the middle. The blue is a dye that allows you, a vital dye that allows you to see, animals that are alive, and you can watch the tumor burden. But you could see that CAR was changing the natural history. It was treating disease. The mice were living longer. And so this disease, this treatment seems to be having benefit. This is from, Reinhold Brenchkin when he was at Sloan Kettering. Next slide. So what Brenchkin did, and the group that he was with, Michelle Sadelaine and Isabel Rivera, they treated some of the first patients. And this was the paper from 2013 of the first 5 patients that they had that they treated with relapsed refractory ALL. And again, on the left, these are patients who all of them were relapsed refractory disease. All of them had marrow that was full of leukemia, and all within 1 week there was no detectable disease. And now post-transplant, by 2 months, For 2 months, they're remaining now free of disease. And it turned out all 5 were MRD negative. Now, I want to, like I just mentioned that, I showed that 12-pound roast beef. That's the equivalent of the person on the bottom. And yet that person, all that disease was gone by day 8 with the single CAR T infusion. And of those 5 patients, 4 of them went on to transplant. And the only patient who did not survive is the patient who didn't get a transplant afterward. And that person relapsed. But certainly, these patients otherwise would have been anticipated to have a 10% 2-year survival with our best attempted standard care. Next slide. So this takes us to, that was a small experience from Sloan Kettering. Well, University of Pennsylvania, at Children's Hospital of Pennsylvania, they also did their own study, and I'll show that data in a minute. But what it did is it led to the first, the industry, Novartis saw the data, and they said, they were the first company to say, we're going to invest into this highly expensive, personalized medicine to see if they could commercialize this. And they ran the Eliana study, which was CTL019 is the name that Penn called their CAR T, which is now has a generic name, tisagenlecleucel, and the trade name of Kymriah. It was open label, phase 2. Many centers across the world participated. Next slide. And what the data was, and this came out and was published in New England Journal, 75 patients were evaluable. 46 had prior transplant. 92% were relapsed patients. 8% were refractory. The median number of blasts in the marrow at the time was 74%. High-risk genetics. Only 8 patients went to transplant after CAR T. And what they found is 80% of the patients got to a molecular MRD negative remission. And on the right-hand side, you could see as of the overall survival, this was at the 1 year, the median survival was 19 months for the entire group. And then the event-free survival hadn't been reached. So good data overall, and again, different than we would have anticipated. This led to the FDA approval. Next slide. And so the FDA approval came in based on that 83% remission rate, and led to the fact that it was a validated, they developed a validated manufacturing process that the FDA could audit and say it was reproducible. And thus it's now a approach that could be given to pediatric and young adults. So what it was is patients to the end of age 25 could get this therapy through age 26. But if you were 27 years and 1 day old, you wouldn't be eligible for the trial because of the way it was written. Next slide. So at Penn, they also then took the same CAR T approach to the adults. This is basically a schema of their paper that was published in JCO. And what they did is they had 3 approaches. They had a low dose CAR T dose, they had a high dose CAR T dose, and they had a high dose fractionated. Remember, these are patients with refractory disease. The marrow was off 50% or more had completely replaced marrow. And so the fractionated was they divided the dose over 2 days. So they gave a little bit on day 1 and then gave more on day 2 and followed the patients. And you can look at basically by cohorts, I will tell you that the firm line, the fractionated dose, that the overall survival was excellent, including patients who had prior transplant. And what's more is all the way down the bottom, if you went to transplant afterward, you did better yet. 80% of patients alive at 4 years. So these are adults now. These aren't children anymore. And we're now able to take and show that CAR T can be given to the adult patient. Next slide. So their clinical summary was, in pediatric, it's very efficacious. In adult, it's very efficacious. What they did learn, though, is you can have severe cytokine release syndrome. It can be predicted by how much disease you have up front and what your serum cytokines and how inflammatory you are. But they also learn how to manage it. They were the ones who discovered that anti-IL-6 antibody therapy can be effective. They also identified the neurotoxicity and other toxicities. So they were the first also to create a scale called the Penn scale for how we grade these toxicities. And by the way, since then, most people do everything possible to reduce the disease burden in the marrow to under 50% before giving CAR T, as opposed to trying to treat these patients with high disease burden, because it does decrease toxicity. Next slide. So that is the Penn experience in CAR T, but there's only one commercial product now for CAR T, for adult CAR T, and that's brextocabtagene. So in the same way that Novartis invested in the Penn experience, the National Cancer Institute, James Kuykendorfer, developed CAR T therapy, and he out-licensed the technology to Kite that ultimately got bought by Gilead. And they have a different CAR T. It is a different molecule. And they use a CD28 binding site, which you can see on the right, a signaling domain versus a 4-1BB. People believe the 4-1BB is more predictive of persistence, and CD28 is more likely to give you faster cell expansion. It is the same SCFV, the same binding site that is, from the same hybridoma. So the binding aspect is the same, but they have their own different culture conditions. Also, the tisagenlecleucel has a lentivirus vector, and the brextocabtagene has a retroviral vector. A retroviral vector to infect the cells. Either way, they created an adult ALL study. You had to be 18 years old or above. You had to have active disease at study entry, so for measurable disease. 71 patients got their apheresis. Now, patients can die before of leukemia progression before you treat them. So 55 patients receive brextocabtagene. Next slide. And what we show, this is just showing basically, I will concentrate on the bottom right figure D, which shows that if you are in CR, that you got your brextocabtagene, your likelihood of being overall survival at 1 year was close to 80%, and the median overall survival wasn't reached. If you were treated and you never got to a CR, you could see that's the red, and those patients did poorly. So if brextocabtagene does not get you a CR, your chance of being alive at 1 year is down to like 25%. So when you actually mix the patients who responded and those that didn't respond, you have that middle curve, the black curve. So you have about 60% of patients alive. And they have these, and importantly in the upper left is if you were able to get to remission, high likelihood it would be sustained. Slide. That led to brextocabtagene getting FDA approval as a CAR T product for adult ALL. Now, brextocabtagene is the same construct as used for Zuma-1 for large cell lymphoma, but if you go and read the differences between ALL and between lymphoma, there's only one difference. When we do an apheresis and it gets sent to the company, there's a proprietary step. They have not published what that step is, but there's a proprietary step before they start the gene therapy, the gene and the T-cell expansion. Personally, I think it's just going to be some sort of selection. Either they're depleting, using antibody depletion, or they're doing an antibody selection step, but it is not reported what it is. Next slide. the summary, this is a summary of a variety of adult ALL trials. Penn, Fred Hutchinson, Sloan Kettering, Beijing, London, and another study from Japan showing, another study from China showing that basically high remission rates and many patients go on to transplant. And the weight, you can choose not to go to transplant, but I think the transplant question remains unanswered. And so that is something that we want to solve long term. But so high remission rates, mixed reporting of who goes to transplant or not. Next slide. So to give you some very recent data, so I put in bold the name Jessica Leonard. She's one of my doctors, and she's one of our ALL CAR T docs that I've helped develop here. But we've taken our institutional data and added it to a real world effort. This is a group of institutions got together and put their data together and saying, can we see what is our experience in relapsed refractory ALL? This was a talk at ASCO. Next slide. So now we're not looking at selected patients on a clinical trial. We're looking at real world. So we want to understand the patients that are going in, what their clinical course was, what toxicities they experienced. We know this is a retrospective cohort study, IRB approved. You had to be adult and you had to have gotten brexucabtagene, and it was 13 U.S. sites. Next slide. So there were 76 patients infused, median age 44. You could see that lines of therapy was 4. Half the patients had prior blinatumomab, half the patients had prior transplant, a third of the patients had prior immune conjugate, and 70% of patients had active disease at the time of apheresis. Of the residual, there were patients that were in complete remission. And importantly, there were 11% of the total population had active CNS disease. Next slide. So what did we see for toxicity? Oh, sorry, skip that. Next slide. What did we see for toxicity? We saw that basically CRS is common. 83% of patients had CRS, but the vast majority was grade 1 or 2. Next slide. Or click it again. If we look at neurotoxicity, that's what the backslide, sorry. I was just saying click it again. We could leave. I can just tell you that neurotoxicity was, you're getting ahead of me, sorry. Neurotoxicity was, you're way ahead now. Oops. All right, catch up to slide 36.
1 second. Let me share that again. $36.
36. I think what I'll do is get through the ASCO and then we'll stop. There will be other information that'll be available, but yeah, so this is just saying, so, well, sorry, that was showing that ICANS, we also have ICANS, and ICANS rate is at about 60%, of which, half of them got grade 3 to 4. So ICANS was very common with brexucabtagene. If we look at the duration of response, though, you could see at 6 months post-treatment with brexucabtagene, if you were still MRD positive, there's a good chance over time that your disease is going to relapse. And at 6 months, if you're MRD negative, you're like, is a good, 83% of those patients remain in remission. Next slide.
I'm very sorry. 1 second. The computer, it's not working.
Okay, so if you, yeah, that's that slide. The next slide, so.
Can you see it?
Yeah, I can just talk through it. Well, let me just tell you, so if we are, Yeah, so that's the progression-free survival. Again, says that, so if your disease is, if you're MRD negative, you're gonna, sorry. Yeah, so the MRD negative patients did well. MRD positive, they high rate of relapse. If you never could clear blast,
อาจารย์เดี๋ยวโทร
those
กลับเดี๋ยว
patients
โทร
all
กลับ
died.
ประชุมอยู่
Next slide. Next slide is the overall survival. And what that shows again is, interestingly though, the MRD positive, when you look at the survival, was actually, even though the MRD negative were relapsing, you might be able to rescue them. And so there's a slide in there that shows that there's a maintenance. If you give treatment to somebody, like transplant them, you actually could rescue them and keep them alive. So maybe you don't have to treat every MRD negative patient, but the MRD positives you can rescue with transplant for sure. Conclusions is next slide. So this is commercial brexpiprazole. Complete remission was common, 80%, over 80% MRD negative. Also common to have CRS and ICANS. Duration of response is promising, can be improved by maintenance. The maintenance is if you had pH positive ALL, if you put them on a TKI, and if you had pH negative, if you took them to transplant, it looks like those patients also did better. So next slide, this will be the last one. I'm going to leave this as a promisorial note, and you guys can look at the slides on their own. So I have another 15 slides about what's new. And this is all since 2020, that we have new novel CAR T products. So we're seeing CAR T that for CD19 failures, there's CD22 CARs, there's 1922 CARs, there's 1920 CARs, there's new manufacturing approaches, there's new target antigens, there's off-the-shelf CAR T for ALL, and getting at the end is the unsolved question. Should all CAR T patients be consolidated with, allogeneic transplant? And I know it's probably too far to go down, but if you went down to slide 53, 53 is what we call the NCCN guidelines, which is, the NCCN guidelines in the United States is how a lot of people will, if you go down 10 slides, maybe, how a lot of people guide their standard of care management. Well, what they're saying is, right now, when you have relapsed refractory disease, you take patients to CAR, they say you do take them to CAR. The final step is you should always consider transplant afterward. Whether you do it or not, and whether you need to do it is an unsolved question, but you got to think about it. And then finally, there's the last few slides, which takes us to slide 54 to 60, is saying, is talking about the cost of CAR. Because what happened is these are great therapies, they're helping people, but they're not available to enough people. And that access to care is something that we have to solve. And I know that's something you're interested in doing, and I'm sort of really looking forward to talking with in detail when I come. And the very, 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 very last slide is, I know that Thailand is famous for their beaches, and that's like slide 61. And I don't know if you can get to slide 61, but I was going to say Oregon has a different type of beach than, what you have in Thailand. And this is where I just had my 2-day summer vacation. And this is where it was. This was a beach. So this is Gerhardt. So this is our beaches. And you got 3 miles of beach and almost nobody on it. Like the entire Oregon coast is very, very unpopulated. And it's lovely. This is the Pacific Ocean looking, we look west. If you look at the Pacific, you're probably looking east. But anyways, just to give you another snapshot, a picture of Oregon. So hope that, I think this could be a resource. I think there's a lot of good information in here, and I hope it's useful to you. I can answer questions for the next 10 minutes or whatever, or we can talk about whatever you want to talk about next or next month or whatever.
Thank you, Richard.
Oh, sorry, can I turn off the slide now, or do you
Please
need?
turn up the slide.
Okay, cool.
Thank you very much, Jenny, for being my guide.
Yes, thank you, Jenny. And maybe we could start any questions from the group. Dr. Surapon, anything you want to ask based on the presentation that Richard just gave?
Yes, I think Richard giving a very nice and informative talk. Yeah. So how about how to treat the extramedullary relapse after CAR T therapy in ALL?
You know, I think it's is that after CAR T or after leukemia
After CAR T.
After CAR T?
But the patient has still the bone marrow remission.
Uh-huh. What we have done is, if it's a localized relapse, not CNS, if it's localized, extramedullary, we've actually used radiation. And what we have actually done also is use, we've gone back and used bispecific antibody. We've given blinatumomab. Because if there's any CAR T that's still there, you can ultimately, so if you use radiation, you might debulk it locally. And if you use blinatumomab, if you still got viable CAR T in there, you hopefully will bring it to the site of disease.
Yeah. So
the other, by the way, sorry, that's what you can do without anything else. What obviously is what's coming out of the NIH group now, and Crystal Mackel came from the NIH, who's now at Stanford. They are developing the CD22 CAR for patients who have had a prior CAR. So if you have a CD19 CAR, you can then come in, if you have access to a CD22 CAR, you could try to rescue with the CD22 CAR.
Can we use allo CAR?
If you could use an allo CAR also. There's a slide in there I show of the UCART program from England, which is they have the most mature data for allo CAR. They're just not as, and again, that's for relapsed refractory leukemia. You seem to have a greater risk of relapse, or less efficacy with the allo CAR T for ALL than you do with the auto CAR T. I think another question is whether or not you would do another allo transplant. Because, if you could do radiation to the extramedullary site, and then you could come back, use either the same donor or different donor, depending on if it's over a year since the original relapse.
Good. So, do you think there will be a role for bispecific or CAR T as upfront treatment in high-risk ALL in high-risk ALL?
Yeah, so that's a good question. So right now there are a number of clinical trials where they're advancing CAR T closer and closer to, not third line or fourth line, but early on. I haven't seen studies yet there's a pediatric study right now going on. So if you are induction therapy and you're MRD positive, after induction therapy is to use CAR T to get someone to transplant. So that's the most advanced, the earliest application of CAR T right now that I'm aware of in ALL. I think a lot of, in the United States, blinatumomab, the bispecific, has gotten FDA approval, not just for relapsed refractory ALL, but now for MRD positive disease, that you could treat the MRD positive ALL with blinatumomab, put them into remission, and we're using blina in that case. If we have that situation, we take them to CAR T afterward in actually an MRD negative state. or taken to allo transplant in an MRD negative state. We would do allo before CAR T at the moment.
Good. Yeah. Thank you very much, Richard.
Other questions from our team members? So is this hopefully a useful presentation? It's one of the topics that, you don't see ALL that frequently, but when you do, it's a really hard disease to treat. I mean, AML is much more common in the elderly population. Pediatrics, ALL is more common, but pediatric ALL does better than most. There's a high cure rate, but this adult ALL is still a big dilemma. In our center, we've now we've become a referral center for adult ALL, and I was surprised that we've had, I think I can probably dig up the exact number, but it was close to 70 new cases of adult ALL in the past 18 months.
Yes, I think I agree that the ALL is a very difficult disease to treat. Very, very difficult.
Yeah. And, because we don't see enough of it. And that was partly why the clinical trial where they showed that, like, even taking aggressive upfront therapy, to the adult ALLs is beneficial. So right now we use the AYA, the adolescent young adult, we use the pediatric regimens for all patients up to age 40. Above age 40 for induction, we'll use hyper-CVAD.
Mm-hmm.
And if they're over age 60 to 65, we'll use the EWAL regimen.
Mm-hmm. Mm-hmm.
Well, thank you, Richard. Great presentation as always. You've already sent it to Jenny, so thank you for doing that. Dr. Surapon, anybody else have questions or thoughts from the Thai side?
No, thank you.
Okay, well, I think you'll be visiting soon, Richard. Anything to talk before the visit, or are we just going to?
No, I think what we'll do is probably I'll send some emails ahead because I know we've already put together an agenda with visits.
Yes.
I do think it's, for me, what I really want to do is sort out, I really want this to continue to grow. And we've talked about a number of things. We've talked about, sharing the registry. We talked about joining the registry. We talked about sharing database. We've talked about standards. We've talked about the practice, and we also talked about research.
Yeah.
I think we've reviewed a lot in the last year and a half, just in talks and approaches. And I think the next year and a half is, we already have one of your colleagues is definitely coming for observership for 4 months. I think that's scheduled for the second half of next year. We're still working on Smith and getting his approval, whether he could come for a year of CAR T work with us. And, building that research. And I've actually been taking for a conversation with about whether we have, more create not just your site, but other sites, how we can work on hematologic malignancy care, not just transplant and CAR T. But that'll be part of our discussion.
Good, very good. Yeah, thank you.
Make sure we try.
I am excited.
Yeah, thank you all. Thank you for the work on preparing the agenda. Richard, no other edits you have to the agenda coming up? It sounds like you're good to go with that. So I'll make a couple of last scheduled things to your thing. I'll fix the agenda. Yeah, I'm fixed with the agenda. I've got another thing I got to finish for you. And I want everyone just to know I'm still excited. This is good. I'm enjoying this. I hope this work is that you guys also find value added here.
Okay. Thank you. Thank you very much, Richard. Looking forward to seeing you.